situation relating to the floods and trying to get vaccines into our shelters. But I am here now, and I am sorry that I probably caused you to panic there. I'm just going to share my screen. All right, hopefully you guys can see my slides. It says that participants can see them, so I am hopeful. If anybody cannot see them, please say something somewhere, please. And I just wanted to thank you all for hanging in there. I know it's the end of the day for you all, and it's been a great morning. I thought I wouldn't see the beginning, but then I had to get up to watch Linda's presentation this morning, and it was awesome. So I've been with you during the day here. And I'm excited because we're going to talk about 2 outbreaks at both the population level and also a bit on individual treatment. And we'll talk about evidence-based and sustainable solutions for URI. I did send the organizers a PDF of these slides, as well as the PDFs of the dental materials that some of you asked for this morning. So they can distribute those afterwards. So don't worry if you see something that you think is worth writing down. You don't have to try too hard to get it all. And then last, I'll just do a quick conflict of interest disclosure that I am involved with research that has been funded by both Zoetis Canada and as well as IDEX Laboratories. And this is interactive, so there's a couple polls and a couple places where we'll ask you to share in the chat to share some of your thoughts. So, as you all know from working with cats in shelters, URI is one of our biggest shelter animal health challenges in North America, and this is at both an individual level and a population level. And even though it's very cute, when cats sneeze, URI is a cause of illness and reduced welfare, and still in many cases, euthanasia. The incidence of URI in shelter cats is reportedly as high as 30%, but it varies a lot, with it being much, much higher in some shelters and almost non-existent in others. And most cases are viral, but we don't want to forget about our bacterial friends that also can contribute. The clinical signs tend to be what you are all used to, so we tend to see sneezing, congestion, and conjunctivitis, and then sometimes, more rarely, we'll see other things like coughing, ulcers, and fever. So today we're going to talk about 2 population level cases, and these are both shelters in our shelter system. As you know, our shelter system, if you were with us this morning, we have 36 locations, and most of them are pretty small to kind of medium sized by North American standards. So I'm always envious of the big shelters in Ontario and in Alberta where you have all these resources under one roof. So we don't have that, and you'll see that as we go through. Both of these cases were pretty chronic. They went on for weeks to even months and affected multiple cats who passed through. So not just the cats that are represented here on this slide, but also cats who were there before them who were part of the outbreak, but weren't part of the outbreak investigation because they were now gone. So we'll call the shelter Shelter A and Shelter B for anonymity. And you can see here that Shelter A had about 40 cats in care at the time of this outbreak, and Shelter B had 20. In both cases, about 80% of the cats were sick, but that's kind of where the similarities end. We had different housing types. So Shelter B had a mix of communal and individual housing with outdoor access, whereas Shelter A was mostly communal except for the isolation room and an intake area. And then we also were experiencing public complaints from veterinarians, from adopters, and the shelters that are kind of at the destination point of our transfer program. And that's actually how we recognize this outbreak in Shelter A. So all of the cats that I'm going to show today were part of one of these cases, except for right at the end. And if you want to type in the chat, if you're investigating this outbreak, what additional information would you start to gather? And I'll just mention that the reason we like to use cases of the actual animals that are affected is because even though often we are working at a population level, especially in my role, we don't want to forget that these are animals who came into our care healthy and they acquired disease with us. So wanting to kind of honor their individual nature while we focus on talking about the population. All right, I'm going to open the chat here. So just throw out, what would you do in terms of just with the information that you have? What do you want to know? Yes, exact clinical signs. Vaccines? Yes, absolutely. Ages? Okay, excellent. I love it. They're coming in so fast. I can't keep up with them. All right, so you want to know about ocular signs. Oh, yes, we can talk about that in a bit. Biosecurity practices, housing type, movement of cats, length of stay. Yes. Yes, length of stay, how long in care. Oh, I love Linda's comment about the macro environment, which we'll talk about, signalment, treatments. Okay, yes. Oh, you guys are awesome. Okay, so um, slides here, get them advanced. So on the left side of the screen, I'm just showing kind of where we would typically start in traditional veterinary practice. And many of you went beyond this, which is awesome because you're shelter vets. But obviously you want to know, I think this was the first thing that somebody posted, and we want to know the exact clinical signs, their severity, any mortality, what treatments have been attempted, especially antibiotics, what was the response to those treatments, what are the vaccine protocols for the shelter, and then what are the actual practices? Like a few of you mentioned, like what did the cats actually get vaccinated at intake? And then if any diagnostic testing, like usually PCR panels, but also things like cultures or other diagnostics to assess for viral and bacterial pathogens. And then one of the things I really love is how many of you, I can't see the chat now again, but how many of you went beyond that to think about the types of shelter information that we really need in shelter medicine practice to investigate any type of outbreak. So things like, what is the capacity for humane care in the shelter versus the actual number of cats that are there? The housing type and setup and how is it used? How are animals and people flowing through the shelter? What is the length of stay for cats, both sick cats and other cats? What is it on average? Perhaps does it differ by age? How are the cats and the staff doing? So what is the perceived stress level of both the animals and the people, because they tend to be connected? What kinds of sanitation and biosecurity protocols are being employed? And then community specific information. So things like, what are the intake and adoptions policies and practices in place? What are specific challenges to that location or community? Are animals being transferred in? Can animals be transferred out? And really just always thinking about our shelters as systems where people and animals and the environment interact, and going beyond individual patient care, which may not be necessary for everything, but it is necessary for an outbreak investigation of any type. So I've only put the ones that were kind of important here because we did review all of these factors, and you have like this ginormous spreadsheet, but I thought that would be kind of unfair to put that up. So clinical signs were identical in both locations. So we had sneezing, oculonasal discharge. We had no ulcers, no fever, no mortality, no like otitis media or anything strange, which was a bit of a relief. In shelter A, none of the cats had any antibiotics, and this had actually been going on for about 3 months. So over 100 cats had been sick. In shelter B, many antibiotics had been used, but there was no obvious response to any of them. When we looked at the vaccine practices, so the protocol is that all cats should receive a modified live FERCP vaccine on intake, which is consistent with shelter guidelines. What was actually happening in shelter B is that they were, but in shelter A, what we were seeing is that 53% of the cats had been vaccinated, but they were vaccinated late. So they were vaccinated 2 to 5 days after intake. And shelter A had about 40 cats in care, and shelter B had only 20, but the capacity for humane care was similar for both shelters and sitting around 20. So I'll briefly explain what we mean by that. What we mean by that is the ideal capacity for the number of cats who can be provided with humane care and adopted out within the target organizational length of stay, which in this case was 14 days. We'll talk a lot more about that later. The other thing that you'll notice is the average length of stay here. So this is the average length of stay for all of the affected animals. And you can see that it was pretty high in shelter A at 33 days. And in shelter B, it was at only 14 days. The range in shelter A for affected cats was 11 to 113 days. And for those of you who know a lot about shelter URI, that alone will tell you what the diagnosis is. But we are going to work through it, and I will tell you what the diagnosis was. But first, we have a poll. And I believe Linda, sent me a text. I think she loaded all of these polls beforehand. So you should be able to answer what you would do next. I'll look at the chat while you do that. Okay, so you can probably close the poll unless you've got, if usually get to about 75% of the, the audience, and then we close it. And when you do that, we should be able to all see what the responses were. Okay, aha. All right, so I really appreciate that nobody wants to give all the cats lysine in lieu of more effective interventions. So you guys are concerned about the lack of vaccination at intake. Nobody wants to give them all long-acting antibiotics, and some of you want a diagnosis. All right, so excellent. So yeah, I think these are the main considerations. And what we chose to do next was we chose to do multi-pathogen respiratory PCR panels, but I will talk about these other options as we go along. And so we don't think of these panels as a first-line diagnostic for any individual cat with URI. And in fact, we only tend to use them to develop overall management strategies for population-level cases. And these, in our hands, are typically either URI outbreaks, where there's transmission and care, or incoming hoarding cases where they almost always have URI if the population is big enough. And we want to know what those organisms are. The good thing about using PCR tests for feline URI, unlike CIRDC, is that we don't tend to see a lot of unknown pathogens. Like, we almost always get an answer if we do enough tests in a population. And it is recommended to test multiple cats. This increases the sensitivity and positive predictive value of our results. And in an outbreak, we typically try to test at least 30 to 50% of the animals. And we want to test at least 5 to 10 animals because of all of these weird caveats around how to interpret these panels in vaccinated animals. So here are the test results. And some of you may know that these PCR panels actually are expanded and there are more pathogens in them now, but I've included just the main ones that we see positives for. All of these cats were negative for things like influenza. And so when we are interpreting these, it's important to remember that URI pathogens you can have infection without disease, you can have shedding without disease, you can have multiple infections with multiple pathogens, which is really, really common. You can have pathogen shedding after vaccination, and we almost always see a few cats who are completely negative when we take population level samples, even though they have clinical signs. So I hope that one of the takeaways here is that you need population level testing to draw meaningful conclusions about the cause of respiratory disease in cats. And the same thing is also true for most dog cases. So what we concluded from this is that FHV1 was the most likely cause of the population level disease in shelter A, and Mycoplasma felis was the most likely cause of disease in shelter B, and that's super weird. And these two Calici positives that we had were in 12-week-old kittens who had been vaccinated 5 days earlier, and we do see quite a bit of Calici positive PCR after vaccination. So the population level pattern didn't fit with a calicivirus outbreak. And calicivirus is one of the only pathogens I'm not really going to talk about today, because that pathogen specifically is very different from other URI pathogens, and we often manage it more like a true outbreak, like where we're really concerned about things like biosecurity and the durability of the pathogen. So what we're going to talk about here is bacterial URI and what we've done in shelter B, and then we'll spend the rest of the time talking about shelter A. And I have just one slide about Mycoplasma because I found out a fun fact, which is that they're the smallest free living microorganisms in the world. But I wanted to include this slide because it's very unusual to have an outbreak where we suspected it's a primary pathogen. In fact, this is the only one that I've ever seen. And though we do see it a lot. So this organism, as you probably know, it can be present in normal cats. In studies, it can be present in up to 80% of normal cats. However, we don't see that kind of prevalence in cats. Like when we test incoming cats for a variety of reasons, we don't see that here. So we don't believe that it's anywhere near that high here in BC. There have been studies that have found that it is more frequently shed in cats with ocular or upper respiratory disease. And in our shelters, like I said, we don't tend to see it that often, and certainly not as a primary pathogen. If you do see it as a pathogen, you'll often see conjunctivitis as part of the presentation, as with Chlamydophila. It's not in the vaccine. Transmission is like other URI pathogens, easily killed with routine disinfection, like other URI pathogens besides calicivirus. Does not have a cell wall, so we have to be careful what antibiotics we use, and we'll talk about that. And one interesting thing about mycoplasmas is that they actually have a lot of genetic alterability. And so what this means practically is that if you have a population of cats in a shelter and those cats have a population of mycoplasma, and for some reason, in one cat, that mycoplasma gains the ability to evade the host immune response and cause illness, and then it spreads between cats, then you can see an outbreak in a shelter, even though this is not normally thought of as a serious pathogen. The other time that we can see shelter outbreaks is when cats are in direct contact, especially if there's crowding or immunosuppression. And where we really usually see mycoplasma as a player is when it's a co-infection with other pathogens. So that's where you're most likely to see it. And just briefly, because it is always important to consider the role of crowding and the role of stress anytime we have a cat disease outbreak. Shelter B was not over capacity. They had multiple flexible housing options. They did not feel like the number of cats or the cat stress was higher than usual. I visited this branch not during the outbreak, but actually a couple months before. And I agreed with that assessment. And this location has a bunch of other locations, including some within only 45 minutes of a drive. So they are able to avoid taking in cats when they need to and kind of shuffle things around to avoid going over capacity. So this is also one of the only outbreaks that I've ever seen where the shelter wasn't over capacity. All right, so the antibiotics. So these poor cats had been on a lot of antibiotics, and this was either because they had significant ocular nasal discharge or because they had another like other condition like a skin issue or urinary issue where some of these are appropriate choices. And we talked about it this morning a lot, but for those of you who weren't here, we only use local vets for our medical care. So this shelter doesn't have a vet. And I only tend to get involved with like population level protocols or outbreak investigations. So basically all of these antibiotics had been prescribed by local vets individually, and none of these vets were aware that these cats were part of a URI outbreak. In fact, they weren't, in fact, the shelter staff didn't recognize it as an outbreak because their overall cat population is not very high, of like 15 to 20 cats at any given time. So these cats were on a whole bunch of different antibiotics, which enabled us to see very quickly. When I looked at the spreadsheet, I was really surprised that they had been on many antibiotics with no apparent response. There were also cats, some who were on lysine with no apparent response, and we were also using Filoay in the shelter with no apparent response with URI specifically. So that brings us to the second poll. Linda, if you can launch this, now that I've kind of lectured you about, about mycoplasma, which antibiotic would you choose for this population, assuming that you agree that the clinical signs are probably from mycoplasma? So Linda, I'll let you make the call when, when to close it, as you can see people as it comes in. Aha, okay. Okay, excellent. So we've got a lot of different responses, but the most popular ones are doxycycline and azithromycin, which is what I was expecting. Okay, perfect. So remember that mycoplasmas don't have cell walls, so beta-lactam antibiotics like clavamox aren't effective. When we look at our drugs like chloramphenicol, fluoroquinolones, azithromycin, they have some effect against some mycoplasmas, but they're actually not recommended as a first-line treatment in shelters. And those reasons relate to efficacy, risk, and antimicrobial stewardship, as well as, we heard Alex talk about this, really valuable information over the past hour, as well as cost. So azithromycin is a popular option and definitely is sort of a second option to doxy. However, many shelters are not doing PCR on these animals. As I said, we don't recommend it for routine cases. And azithromycin is not as effective against Chlamydophila, which can cause similar clinical signs to Mycoplasma. So if we're treating URI empirically with antibiotics in shelters, azithromycin is not a great choice for that reason, because we might not be treating our Chlamydophila if that's what's present. When we talk to community vets, because of course all of our antibiotic prescriptions for shelter URI have to come from community vets, unless I happen to have seen an animal in my home location, which is usually not the case. A lot of community vets have really internalized this idea not to use tetracyclines in juveniles, but in practice, we don't see the tooth discoloration like the enamel staining with doxycycline specifically, though we do see it with other tetracyclines. So we have expert consensus guidelines for URI that I'll pop up here in a minute. And those expert consensus guidelines recommend that doxycycline is the first line antibiotic down to animals who are 4 weeks old, and that the treatment duration is recommended to start at 7 to 10 days. And some shelter medicine references do state that it should be 2 to 3 weeks. We take a middle ground, and we typically treat Mycoplasma for 14 days, and then we extend in 7-day increments. It is also worth noting that Chlamydophila requires a longer treatment duration of 3 to 4 weeks if it happens to be in the mix. Oops, I'm going backwards. Did not mean to do that. So this is, you guys probably have all seen this, but this is the reference. It's open access. It goes through all the different presentations of URI in cats, as well as lower respiratory disease, as well as canine respiratory disease. It also talks about antibiotic selection in detail, and it also talks about viral diseases briefly. And so I always love this and send it to community vets who want to put all the cats on like Baytril, for example. It's a great reference. And so just highlights from this, again, most URI is viral. And if you've worked with cats or if you have children, you know that viral URI can absolutely cause mucopurulent discharge. So we don't put all cats with mucopurulent discharge on antibiotics unless there's clear indications of a bacterial infection, or we know that we're worried about one in the population. These guidelines also recommend a brief monitoring period before starting antibiotics if we're treating empirically, and that's why. But if antibiotics are needed, which again is pretty rare, doxycycline is the first choice. And this is not just for feline URI, but also for CIRDC. If, again, that's also usually viral, but if you need antibiotics, doxy is the first choice. And so I'm briefly I don't want to like totally ignore the other bacterial URI pathogens. So I did put the other two that we think of as primary there. They all have similar antibiotic choices, all 3 of the primary ones. And remember that Bordetella and Chlamydophila have implications for other species, including being zoonotic under specific circumstances. I put the streptococcal species with question marks because some recent work does suggest that some of the streptococcal species can directly cause URI and other related clinical syndromes, like otitis media in cats, if you've read some of Linda's work. But it also appears that even when they do that, they may be more chronic and opportunistic, as opposed to like they're spreading between cats, they're a primary agent, they're causing acute primary disease. So I also just wanted to mention quickly about Ocular Meds, which we like using Ocular Meds a lot for URI. I used to use them in all my URI cases, and now I almost never use them. So especially things like herpes, Mycoplasma, Chlamydophila, we can see conjunctival manifestations. And if it's bacterial, remember that if your patient is on doxy, you are treating these from the inside out. You have really good vascularization in the conjunctiva, and additional eye meds add cost, they add stress, and in a case of tetracycline-based eye meds, they sting a lot. And so you may not need additional eye meds for like routine bacterial conjunctivitis type cases. If you do use them, a note that you want something with tetracycline, erythromycin, or chloramphenicol to have the best activity against primary pathogens. And a reminder not to use BNP in cats. It's cheap, it's readily available, but it does carry the rare possibility of severe anaphylactic reactions, which are always good to avoid in a shelter. So I'm curious if you want to just type in the chat, and then we're going to talk about the second case. Why did this happen? What were the root causes, not the actual pathogen, but why did this shelter have this weeks-long URI outbreak? Oh yes, so we're talking only about shelter B. I'm going to ask you the same question about shelter A though, but I will give you more information about shelter A. And that is correct. But for shelter B specifically, why did this happen? Like, what information do we have that told us why these cats, why this persisted in the population? Okay, so people are concerned about cleaning, disinfection, mixing of animals. Okay, so yes, those could contribute, but if you go back, like what was the root reason? Not not necessarily, like what could the staff have done to prevent this? What could the staff have done to limit this to the first case? I guess I'm not asking the question very well. Okay, so yes, Dr. Gunn, treatment was never appropriate. So this, so again, just for shelter B, which has a URI that's attributable to mycoplasma, so it's not in the vaccine, though that is a concern for the next one. The thing that caused this outbreak, kind of the root thing that caused this outbreak to perpetuate, was that the first couple cats that were congested got the wrong antibiotic. And that's why this outbreak happened. It's not because they weren't cleaning. It's not because they were over capacity. They weren't over capacity. It's not because they didn't isolate the cats, though I guess if they had isolated them, it's possible that they could have limited it further. But you don't have to isolate cats with URI. I know that's an insane statement that I just made, but I think that we isolate cats with URI too much. So I only isolate cats if they have clecy. We don't isolate any other URI cats in our system. So, I mean, yes, not housing them communally may have helped, but they did have individual housing for cats who didn't do well in the communal housing. So I think in this case, and I obviously know our system better than you guys do, so I can cheat a bit, but I think really it was because the first antibiotic wasn't the right one. And then secondarily, because of our system and not having a great, like if it had been one vet who had seen, 30 cats over a 3-week period from the same shelter with URI, they probably would have been like, something's wrong here. But because it was like 12 different vets who saw like 1 or 2 cats each, they were just like shelter cat URI, like I'll put them on Plavimox or Baytril or whatever. So we did not identify the problem in a timely way. I think I might have missed something in the chat here. Yes, not identified. Okay, so this is a shameless plug and a small break between the 2 cases. For a new organization that our shelter medicine technician is really involved with, she's on the board. The ASMBT is bringing together shelter medicine technicians to support growth and leadership in shelter medicine and work toward a veterinary technician specialty in shelter medicine. So I'll put this back up at the end and it'll be in the notes, but I really encourage you to go to their website. You can fill out a form to stay in touch with them. You can go to their Facebook page. They welcome vets who are supporting this as well as technicians. And I would really encourage you to check them out. Okay, so this is the last poll. And I'm sorry I keep giving you guys things to do here, but it's always good to see where everybody is. So Linda's launched it. So remember, this is just shelter A. And sorry, I should have maybe put the shelter A, shelter B summary up again. So this is just shelter A, which was the shelter that had the feline herpes virus primarily on their panels. All right. Awesome. Okay, I love this. So you want to get vaccines at intake. and you want to reduce the length of time that the cats are in the shelter. And I totally agree with those. Okay, so let's talk about what we did here. So again, I just have one more wordy slide about feline herpes virus 1. You guys are probably very familiar with this pathogen. This is a ubiquitous virus that the vast majority of cats are exposed to as kittens. So in one study, 97% of cats were previously exposed to this virus. Approximately 80% become chronic carriers, and they go on to kind of have this virus that can be reactivated throughout their lives. This is a virus that is associated with stress, and I know a lot of you know that from some of the comments you made in the chat about stress management. And so this virus is so associated with stress that we can actually measure the shedding of this virus, and it's a way that we can measure stress in shelter cats. And while it can be transmitted directly between cats, the current thinking is that in sheltered adults, reactivation is what causes them to become clinically sick. And so we tend to see viral shedding and clinical signs that start up about a week after a stressor, like being moved or coming into a shelter is what we see. And so there is a vaccine, which is very worth using. It can decrease both severity and shedding. It does not induce sterilizing immunity. It does not prevent infection. And like all the other URI pathogens, except calicivirus virus, this is a very wimpy pathogen. So environmental cleaning is actually not, I mean, obviously we advocate for a clean environment, but it's not the solution to this type of URI, nor is it the solution to mycoplasma. We can see worse clinical disease if we are young or immunosuppressed or have a co-infection, which is, again, similar to other URI. And if you take a bunch of normal cats who are in the community who are not stressed, or basically the shedding should be very low, like it should be around 5%. So even though 80% of cats can carry this, you should not detect it in anywhere near that percent of cats. And it's very correlated with longer shelter length of stays, especially once you get above that kind of 10 to 14 day range. And if you remember, the length of stay for the cats that were affected in shelter A was 11 to 113 days with an average of 33 days. So it's very consistent with this virus as a cause. Treatment is largely supportive, but I will talk about a couple of individual treatment things as we go along, but that won't be the focus. I know all of you are experts on the individual treatment of cats with URI, so I really wanted this to be more about population level casework. So in shelter A, when we dug deeper into some of these factors, like I showed for shelter B, we found very different answers. The first one is that 100% of the housing in this shelter outside of the isolation area and the intake room was communal, and all the communals were kept full at all times. And they would take one cat out and then put one cat in, or take two cats out and put two cats in. So they never emptied. So these cats had new roommates constantly. The manager and the staff, when asked very gently, they immediately were like, yes, we're so stressed. The cats are so stressed. There's too many cats. There's even more, there's like 200 cats that are waiting to come in. Like we just can't keep up. And so their staffing level was basically for 20 cats, but they had 35 to 40 cats for like months at a time. So needless to say, they were very stressed and they felt overwhelmed and they felt like they couldn't do a good job. And then as a result, things like our intake vaccines and our daily monitoring and weekly weighing were not able to be performed consistently. So now that you have some information about this outbreak, again, not the pathogen, what is the root cause? Why does this shelter have a URI outbreak? There is one single answer to this question. The primary root reason why this shelter has sick animals. Yes, yes. So they're over capacity, the animals are stressed, which is what happens when you're over capacity. Everyone is stressed and they're in this vicious negative cycle that has now resulted in veterinarians in the community not wanting to work with them, veterinarians telling their clients not to adopt from the shelter because all the cats are sick. So one thing that I do want to mention here about vaccines is that not being able to vaccinate everyone at intake in this case was a symptom of this outbreak. It is not the cause of this outbreak. So things like FPV, like if you had a feline panleukopenia outbreak and you vaccinated 53% of your cats 2 to 5 days late, you would absolutely have devastating widespread mortality. And intake vaccines are so important, largely because of the parvoviral components in them. But we don't want to, I think our historical reaction to URI outbreaks is to vaccinate more and earlier and to clean more. And I would make the crazy statement that in this case it wouldn't matter, and that the resources should be put into something else. So of course we want to look at the vaccine timing, but in this case it told us that the staff are over capacity and they can't take care of these animals. So we're going to spend just a few minutes talking about what shelter aid can do to improve cat welfare and health. And this will be based on some of the research that's been done over the past 5 years about what cats need in shelters. So you may have some ideas and I want to hear them. What adjustments, if this were your shelter, besides things like vaccine intake, making sure that the sanitation protocols, everything is correct, the fundamentals, what adjustments would you make to get them from where they are now to where they don't have URI anymore? Yes. So you want to put some in foster care to reduce the number on site at any particular time. Yes, you want to know how are they flowing through the shelter and like, are there bottlenecks? Why are they staying here for a month on average? Manage the communals differently. Yes, lower the number of cats, manage entry, community-based sheltering, decrease capacity back to 20. Oh, you guys are awesome. Okay, this is fantastic. Okay, so you can leave and you don't have to stay for the second part. I'm just kidding. I want you to stay. So many of you have seen this study. This is one of my favorite studies, and they looked at 9 shelters and they found 2 things that were protective for URI. One was having a cage that was greater than 8 square feet in the initial, like at intake, basically, at the initial stay. And the second was having 2 or fewer moves in the first week of your stay. So again, telling us how critically important that transition into the shelter is for cats and how important it is for us to try to find ways for that not to happen. We know from older studies that moving cats can cause FHV1 reactivation, that a length of stay over 7 days increases the risk, and that it continues to climb for the first few weeks in care. And we also know that traditional cage housing for cats, and I've seen this changing in Canada, but I know in the US it's often still the case, that cages are only 4 to 5 square feet in total. And the ASV guidelines say to have 11 square feet, and this study looked at 8 square feet, which is kind of in between those. So cats need high quality housing or else they will get sick. And this is part 1 of a 2-part open access series that you probably have all seen. It is linked in the references, so you'll get that information afterwards. But this basically goes over kind of cats need cage size and setup that allow expression of normal behaviors, that allow them choice and control over their environment. And something that we often kind of neglect to think about, but it's super important, is the room environment. So the macro environment, and Linda mentioned it, how close are they to dogs? That wasn't because like they don't like dogs, it's because of noise. Dog noise is extremely stressful for cats. So things like that we forget about, but things like lighting, noise, the caregiver routines, plus the microenvironment of the cage are all things that we should be considering when we house cats. So when we tie all of this together, we get the capacity for care management model. And I know that some of you are C4C pioneers in Ontario, so some of this might be review. But this model does 3 things. It optimizes the number of cats that are housed in the shelter at any one time. It manages length of stay to be as low as possible, and it provides high quality housing for the cat. And so this is a study of what happened when C4C was implemented in shelters in Ontario. And I'm going to talk about the story of C4C because it's like my favorite story in the whole world. So C4C in Canada actually started in 2011 on this day that's pictured here, when the UBC Animal Welfare Program and the BCSPCA co-hosted a session by Dr. Kate Hurley about her early work on adoption-driven capacity, how to right size your population and know how many cats you should have. And this is kind of based on that revolutionary idea that if you have more cats at once, you won't necessarily adopt out more cats over a whole year. What you want is a thoughtful approach to house the right number of cats at any time, meet their welfare needs, and maximize adoptions. And so Dr. Kate Hurley, who obviously you all know who she is, and she has many honors to her name, was extremely excited about the size of this sign. She said no one had ever made such a big sign for her before. So I love that. And what this team did was absolutely revolutionary for us. So in 2012, we piloted C4C in our Vancouver shelter, and we found that adoptions went up 15% over the year. And instead of having 12 to 16 cats at any one time in our isolation ward for URI, we had about one on average at a time. And our length of stay went from 40 days to 22 days in that one shelter. And we decreased the physical holding capacity by portalizing kennels to less than half of what it had been. So that's scary, right? Like terrifying. It was terrifying at the time. And then in 2012 to 2014, we implemented it across our other 35 locations. And in 2014 to 2015, the UC Davis team helped 3 other Canadian shelters implement C4C. That was the study that I just showed you from Dr. Karsten. And they found reduced length of stay, increased likelihood of adoption, and a lower probability of euthanasia or death, as well as decreased URI. So that looks like this. This is from Dr. Laurel Gale, who's not here today, but she's from the Kitchener-Waterloo Humane Society, and she kindly kept in touch with Dr. Kirsten and sent her this image from a couple of years after the study was published. So what you're seeing here is the yellow and blue lines are before C4C, and this is the number of cats that was housed in the isolation ward for URI treatment at any one, in a month, I believe. So it's kind of a proxy for the URI incidence in this shelter. They implemented C4C in 2014. So what you see here essentially is that, it was in 2014, 2015. So what you see here is that all of the other lines have just plummeted down toward the baseline of this graph because they had very few cats that were being treated for URI. The other thing that you see from that black and red line from 2018 and 2019 after the study period ended is that C4C is results in a sustainable improvement without like an ongoing investment or additional changes. Once you take that cycle, that negative cycle, and you start to put it in a positive direction, you can have long-standing benefits from it. So just to recap, the 3 main things that C4C does, and we made an infographic because we have so many shelters and we have so many staff and volunteers. Many people are naturally resistant to some of the concepts in C4C, and I'll talk about that in a moment. But we made this infographic for those people. And I'm just going to mention, I think everything on here is pretty self-explanatory, and I can tell that you already have a lot of expertise in these areas from your responses in the chat. But number 1, for those who aren't familiar with this abbreviation, is that this is the adoption-driven capacity formula. So it uses our monthly, daily average adoptions, like what can we achieve with adoption, which is our primary outcome in many of our locations, and the target length of stay. So not the current length of stay, which for this shelter was 33 days. The target is 14 days in our organization in general, in most locations. And this tells us how many cats should be in the shelter on an adoption pathway at any particular time. And then number 8, where I say optimal animal management, and Alex mentioned, he could talk about rounds for a whole day, and like I totally agree. Optimal animal management is things like daily rounds. It's things like assigning action items out of rounds. Essentially, it's the philosophy of asking each animal every day, looking at the animal, the environment, their paperwork, and asking, are you better off today than you were yesterday? And if not, what can we do? We must take action if the answer to that question is not yes. If you're the same or you're worse, something else needs to be done. And really taking that philosophy and putting it into every single thing that we do every single day. And that's really scary. So this outbreak happened in 2014. The rest of the province was implementing C4C, but it wasn't fully in place. And the cure for this outbreak was to get the rest of the way there. But that required thinking about things differently. And it seems like many of you are kind of over this hump, but if you're not, or if you're working with people who aren't, which is likely in the shelter and rescue community, then it's worth briefly touching on some of the things that we did. So our manager of animal welfare, Kim Monteith, and I wrote a report, and we supported the shelter for a few months through recommendations in these 4 areas. So for intake, we, and I think you guys came up with pretty much all of these. So we encourage them to use a managed intake list, but not to just passively put people on a wait list, to actually see what people needed and try to support them during that time. We grew the foster program, which was very small, so that we had that virtual capacity. And then we also talked about ways to avoid taking in cats if we're over capacity, because it doesn't benefit them to take them in and let them get sick along with everyone else. We also talked about starting pathway planning at the time of the intake exam instead of sort of passively waiting, like, okay, the stray hold is done. Okay, no, I'm going to make a spay neuter appointment. Like just really trying to like really ask every cat what they need every day. At the time of this outbreak, this shelter had very draconian measures for visitors and adopters. So basically, if you came into the shelter, you in the reception, somebody asked you why you were there, and if you wanted to see the cats, you had to fill out a 5-page adoption application. Like you were handed a clipboard with a 5-page adoption application before you could pass the reception area. So all of these cats, these 35 to 40 cats that were all sick for months, different cats that came in and got sick, were behind this wall where we wouldn't let people in to see them. We were also moving cats. So like cats would come in, they would go into an intake room for the stray hold. Nothing would be done during that time. Then they would move to one of these communal rooms, and like there was a lot of movement that wasn't necessary. But that was in part because all the rooms were communal, and you can't just house a new intake. You can't just put a new cat into a room full of cats. So we started open selection, allowing viewing during stray hold, and recommitted to those daily animal management welfare systems. Remember that if anyone in shelter is transmitting disease, like on their clothing or on their hands, it's the staff. It's not visitors. Some of you flagged the management of the communals as being suboptimal, and I agree. So first of all, it is not a good idea in a high throughput shelter to have all communal housing. You need some individual housing, you need some flexibility. It might be fine in like a sanctuary with a stable population, but this is not a stable population. This is a high volume shelter that has like animal control and stuff. So we committed to the ASV guidelines, giving each cat 18 square feet of space, which required putting fewer cats into each room. Also, we implemented strict all-in, all-out communal management. And this is not necessary long-term, but it was necessary short-term to kind of get this under control. It also forced the staff to really buy into C4C because they just they couldn't think of the rooms as having unlimited space. And then that also enabled us to move cats out of the communals if they weren't doing well. We converted a large communal room to 10 like well-sized individual housing units, and that was all we needed just to make sure that we had that option when we needed it. And then when it was time for cats to leave the shelter, they still had some really stringent barriers to adoption. So we got rid of those, and we started to aggressively promote long-term cats, and also transfer cats out when they were getting close to the capacity. We acknowledged that like, hey, you need more help from the branches around you, and let's get you that help. When the staff who were initially resistant started to see this positive cycle spinning in a positive direction, they started coming up with ideas. So one of their ideas was, let's offer spay neuter vouchers and pay for surgeries for people on the wait list, because we're going to pay for these surgeries anyway. And we don't do them in-house anyway. So like we want to engage community vets to collaborate with them and help them see that we're doing something to address this illness. And then also just make sure that these animals have already seen a vet and they're already altered. So they come in and you can fast track them instead of them having to sit there and wait for surgery. And so what we found unexpectedly was that only 75% of the guardians actually ended up surrendering when we implemented this one change. So it wasn't just because they were on a wait list and they found an alternative, it was also because the problems that they had were sometimes related to being intact, which is unsurprising when we're talking about adult cats. So just for the last few minutes here, we're going to talk about a couple of like interventions and a couple of things that people have lots of questions about. And the first one is the value of a cat. So we have had this narrative for a long time as an organization that, you know, we want people to value cats the way they value dogs. We have cat overpopulation and so on and so forth. And so what's come from that unintentionally is this resistance to lowering or waiving adoption fees. And it comes from the fact that we believe that the value of something may be related to its actual monetary value. And so there's two ways that we kind of try to dispel that. The first one is that there's research on this that shows that reducing adoption fees or doing promotions does not result in a decrease in the quality of adoptive homes or attachment or veterinary care utilization, and it does not result in more returns to the shelter. But for those who do not respond to data, we ask them to think about the things that mean the most to them in life. And for most of us, it's not going to be things that cost anything, potentially. So that saying that the best things in life are free, like when we talk to students, when we talk to staff about this, we really try to just flip that around and say, like, when we are making these cats free so we can get them out of the shelter, we're actually showing the public that we value them so much that we're willing to forego that revenue, that income, so that they can be in a community home, which is better for them. So I think that it's the same message about value, but it's just kind of a different take on it. And that has been really helpful for us in terms of helping change kind of hearts and minds about C4C. I'm not going to talk about famciclovir too much, just simply because we have a famciclovir expert here, Linda, who wrote an excellent blog post on this a few years ago for the OSMA, and it's really good. So if you have questions about famciclovir, go to that blog post. It can help. This is a study from last year showing that it did help compared to placebo cats. In this population, about half of them were shedding FHV1. And they use a little bit of a lower dose than the current kind of optimal dose, which we think of as 90 mg per kg BID. So it's possible that a lower dose may have benefits, but this is a very bitter and expensive medication. So our recommendation is typically to spend resources on prevention and treat cats only if they have severe disease or if they have severe ocular disease where they might like lose an eye. If you're finding yourself in a situation where you're like fundraising because every cat in the shelter needs famciclovir, like this isn't the right intervention approach. There's probably something that could be more effective, but may help. What doesn't help? There's two things, and I'm going to get on a small soapbox here. The first is that everyone gives lysine to cats with URI. And this review found that even though 90% of cat hospitals recommended lysine at this time, there's no scientific evidence anywhere that it's effective for the prevention and treatment of URI in cats. A couple of the studies that were reviewed were in shelter cats. One did find that lysine was associated with worsened clinical disease. And there is a cost associated with giving this product. So if we might say like, it's a supplement, we know it's viral, but we want to do something, we want to feel like we're doing something. Well, and after, listening to Alex talk, like I would argue that in a shelter where the judicious use of resources is both an ethical and an actual like practical limitation, is not appropriate to use something that doesn't work. So I would encourage people to stop using this stuff if you still are. Another thing that doesn't work for URI specifically, though I will acknowledge that in the behavior field, there's very mixed and very weak research-based evidence for pheromones like this. There was a tiny study in kittens where it seemed to help, but it was like 8 kittens. So this much larger study out of UC Davis that was well designed found that in a large shelter with naturally occurring URI, it did not seem to help. So again, not to say don't use a feel-away diffuser or don't use feel-away, because it certainly may help and it's part of fear-free practice, but don't use unproven treatment modalities instead of ones that are effective. So use it as an adjunct. But I've seen cases where it's like, oh, all the cats are sneezing. Okay, I have a whole room of sick cats. Let's put a diffuser in there for like 14 days and then recheck and see see how they're doing. Don't do that. That is not okay. And so a bit of a soapbox about, understanding the limitations of some of these products that get promoted to us. And then just wrapping up here, I don't want to run out of time, so I'm just going to, you don't have to type the cost in the chat. I'll just tell you how much this costs. So we had about $1,200 in PCR tests, but additional kind of, that we didn't try to quantify, additional costs around staff and animal care time and vet bills and reduced ability to help animals and reputational risk. And the biggest cost, I think, is that these animals came into us healthy, dozens and dozens of them. And in our care, they experienced like preventably reduced health and welfare. So outbreaks have costs, they have a lot of costs, and we want to always quantify those beyond the financial cost of them. And then last, so basically since this happened, we've had almost 8,000 cats and kittens come through these 2 shelters. And other than one litter with Clecevirus giving Clecevirus to a second litter in shelter A, we've had no in-care URI transmission at all for the past 6 to 7 years in these shelters. And so I want to close by really reminding us all that we used to think feline URI was absolutely inevitable in sheltered cats. And the reality is that because of the way we manage these cats, it was inevitable. Like it was a self-fulfilling prophecy. And we can't prevent animals. We can't prevent animals coming in with it. We can't prevent animals shedding it sometimes. But The solutions are very simple, and they're not what we used to think. We can't vaccinate or disinfect or quarantine our way out of the common causes of shelter URI. But what we can do is we can give every cat what they need to stay healthy, give them adequate quality housing, minimize how much we move them around, and minimize their stay in the shelter or even prevent it by being very thoughtful and intentional about placing cats into the community where they really belong, and using evidence-based treatment modalities when we have a choice of what to use to treat. So just some key points here again about URI usually being viral, that doxy is our first choice when it's not, that it is achievable to eliminate population level URI or to end outbreaks. And I feel like a bit of a zealot about C4C, but it is the solution to URI and also all other cat-related problems. I have some references here that will be in your slide copy. And these are my shelter cats that are loved beyond belief. And I can take some questions, and I know that we only have a couple minutes left. So I'm just gonna peek at the chat now here and see if there's any questions there. Let's see. A lot of it is just people still having great ideas. There are some here that we didn't do, and I'm like mentally noting them for next time. Oh, good. Okay, yes, Linda put her blog. Oh, I see a question about doxycycline, where we're getting it and what formulation. So doxycycline is, I didn't even get into like the compounding issues, but generally it does have to be compounded. And so what we do is we get it from Summit, which is obviously really close to you guys, and we get it in powder form. And then we, so we don't compound it in-house, but we like reconstitute it in-house. So then we can just basically keep the bottles of powder, like we get them in like the individual 25 ml bottles, and then we just reconstitute them only when we need them. So it sounds like that's what you're doing too. So we also, after talking to Summit, and I don't know, like I realize this is not consistent with published research, but we did talk to them and they believe that their product is stable for 14 days. So, and I know, like, again, do not do this, but we do use it for 14 days. And we have not seen like that between 7 and 14 days, the efficacy seems to plummet, but we're pretty careful. Like we don't use it beyond that. And we also don't use any other products that like, I think that there are definitely some concerns. The other thing is I talked to an internist who said that it actually is safe to give doxy pills to cats as long as you like, as long as you give them a large volume of water afterwards, like 6 cc's. And I was always told like never, ever, ever, ever give a doxy pill to a cat. But I have a cat who needed doxy for something and he won't take any flavored liquids and he won't take anything hidden in food, but he's super easy to pill. And so he ended up on doxycycline for like a month. So I think like maybe we're too cautious about using, like in this case, it was capsules. So I don't know if you have like an internist that you work with that you could talk to about it, but that was something that I learned recently. I'm not a pharmacologist though. I'm not an internist. So that's just what we do.
Okay, I'm not seeing other questions. I think you've answered all of our questions. Thank you. That was an amazing talk. So thank you so much for presenting for us. Thank you to the rest of our speakers, and thank you to everybody who attended today, as well as to our sponsors, our gold sponsor, OVC Pet Trust, and our silver sponsors, Hills Pet Nutrition's Food, Shelter, and Love program, VCA Animal Hospitals, O Genus Solutions, Zoetis, and Flux Media.